Good evening, everybody. So this evening we are going to talk about um, what makes someone a good surgical candidate. Before we talk about what is or who is a good candidate for an epilepsy surgery, I want to build the ground here by explaining some basic facts and some terms so we can discuss that a bit further when it comes to the criteria for epilepsy surgery. So one thing is the concept of medically refractory epilepsy. So medically refractory epilepsy, or sometimes it's called medication-resistant epilepsy, is considered by definition, that is put by International League Against Epilepsy, or ILAE, as someone who has epilepsy and at least 2 medications have been tried in adequate dosage and appropriately chosen for the type of the epilepsy. And those 2 medications for an adequate amount of time have been tried, and they have not controlled the seizures, or seizure freedom has not been achieved. So these situations are called medically refractory epilepsy or medication-resistant epilepsy. Now, why it is important? Because it has been shown by statistics that if someone has tried 2 medications, as we talked about, with adequate dosage and adequate amount of time and appropriate for the type of epilepsy, if the seizure freedom is not achieved, subsequent trial of other medications has a fairly low chance of achieving seizure freedom. And I just wanted to show you this cartoon of how this statistics represents. For example, in this cartoon, what you see here is that if someone has epilepsy and is started on 1 medication, in a largest number of samples of patients with epilepsy, around 50% of them achieve seizure freedom. And then if a second medication is added, then another 11 to 13% of patients become seizure-free. So the total comes to about 61 to 63%, again, depending on the statistics that come from the studies. But then after that, for the 3rd medication, 4th medication, 5th, 6th, and 7th medication, as you see, so these lighter colors here are when the new medication is added. They do not add too much to the number of or percentage of patients who become seizure-free. And that's the basis of this definition of medically refractory epilepsy, meaning, again, if there are 2 medications already tried, any medication beyond that does not add a whole lot percentage. As you see here, these are very small, less than, some of them even less than 1%, for example, for the 6th medication here. And we are talking about not even adding the medications on top of each other. We're talking about trial of a new medication. So that means that we go beyond this point, the chance based on the statistics of control of the seizures become lower and lower. And that's when other ways of treating epilepsy comes into play. And that's when we talk about, epilepsy surgery or neurostimulation. But again, today's session is focused more on the epilepsy surgery. So who is a candidate for epilepsy surgery? So one of the criteria is that the epilepsy should be of a focal type. So what is focal epilepsy? Epilepsies are, sorry, I'm going to just hide this again. All right. So focal epilepsy refers to seizures or epilepsies that come from a focus or a limited area, in other words, of the brain. So that means that there is a focus in the brain that has tendency to generate seizure. And when the seizure starts from that area, then it may propagate or spread to the other parts of the brain. So we call these focal epilepsy, as opposed to the other type of epilepsy in this classification that it's called generalized epilepsy, meaning that there is not one single or small focus that we can find that generates the seizure, but the seizures start from both hemispheres of the brain at the same time. So generalized seizures and generalized epilepsy are not candidates for surgery because there's not an area of the brain that can be removed to control the seizure. Whereas in focal epilepsy, if we find that focus by various tests and workup, then we determine if that area is safe to remove. And when it's removed, there is a good chance that the seizures become under better control or seizure freedom. So that's the first criteria. Focal epilepsy. Those who have generalized epilepsy are not a candidate for epilepsy surgery. Having said that, I have to mention also generalized epilepsy might be a bit different from generalized seizure because focal seizures can also become generalized. Again, as I mentioned, there's one area of the brain that starts the seizure, but when it spreads to both hemispheres, at that point it becomes generalized. But it does not start as a generalized seizure. It starts as a focal seizure, and then it becomes generalized. Whereas in generalized epilepsy, from the onset, it is from both hemispheres at the same time. So that's the first criteria. It is like in lots of other medical procedures or plans, it's a mutual relation between clinicians and patients. So we have to make sure that this communication is adequate. There is enough information is provided by clinicians to the patients so they do understand what is the process is, what is the goals of these surgical evaluation, what is the goal of performing surgery. And so all the questions basically answered before someone makes a decision and wants to proceed. The other criteria is that seizures have to be disabling enough to justify approaching an invasive way of treating seizures with epilepsy surgery. So someone also has to try the medications first, and then if the medications don't work, or in other words, medical therapy that is appropriately planned, if it does not work, then we talk about other modalities, including surgery, epilepsy surgery. During the workup of someone who potentially can be an epilepsy candidate or epilepsy surgery candidate, we do lots of tests, as some of you may be aware, and that includes electrical or electroclinical workup, which means EEG, that I'm sure majority of you are familiar with. So the electrodes that are put on the scalp to record the electrical activity of the brain. And that's the way that we can tell where the seizures are coming from, what type they are, how do they spread, how do they start, and so on. But then also we have some workup that includes getting images of the brain, MRI, or there are some other modalities that sometimes we need to do. So these data that we do during the workup has to line up and gives us a hypothesis that the seizure is coming from this area. We think that there is a reasonable assumption that if we can resect that area, the seizures become under better control. And we have to also, again, make sure that that area that is resected causes minimal deficit as a result of that. So these data has to line up. Again, that would be a good, for someone who has these data lined up, would be a good surgical candidate. There are always in medical treatments, risk versus benefit taken into account. Epilepsy surgery is an invasive procedure, so we take, again, all the risks into account and benefits into account, and all those details will be assessed and discussed with patients before making decisions. Overall, epilepsy surgery is a surgery that is associated with, fortunately, not high rate of complications. And one complications of any surgery can be mortality or death. So the mortality from epilepsy surgery is low, fortunately. And morbidity from epilepsy surgery, meaning that deficits or complications that can happen as a result of the epilepsy surgery, there are a few of them, depending again on what area of the brain is targeted. Some decline in memory or language can be associated with it. Again, these risks are all assessed before proceeding to that procedures with, again, various workups that are done. And not all areas of the brain result in memory or language decline. Depending again on what area of the brain is affected, visual field, like the vision fields, can be affected after the surgery. But as I said, these risks are assessed before surgery and discussed in detail before proceeding. However, on the other hand, there are risks for uncontrolled seizures, as we know. That includes, injuries and, for example, that can be associated with morbidities or even mortalities. So again, these are risks and benefits of the epilepsy surgery versus the risks of the uncontrolled seizures are assessed and before proceeding. Now, again, talking about what makes someone, again, a good surgical candidate, let's look at some demographic also informations. For example, age. Does it have any bearing on someone to become a candidate for epilepsy surgery? Usually, surgeries that are done in younger age has better outcome. It doesn't mean that in higher age would be any contraindication to do a surgery, but usually the outcome, it has been shown, is better if someone does the surgery before age 45. Now, if someone has psychiatric problems or diagnosis, does that diagnosis has any effect on being a candidate or being considered for epilepsy surgery? So it does not. So it has shown for the most part, outcome of the surgery is not associated with specific psychiatric problems. Lots of times even it may result in better control of the psychiatric problem after the epilepsy surgery, such as depression or anxiety, which are very common in general population and even more common in those who have epilepsy. Now we talked about who is a good candidate, but let's also talk about who is really not a good candidate for epilepsy surgery, or in other words, is contraindicated in medical terms for epilepsy surgery. So there are some criteria that are basically absolute contraindications. So it's an absolute no-no. And one of them is the one that we already talked about. So someone who has generalized epilepsy, and sometimes again in medical terms, we call them primary generalized epilepsy or genetic generalized epilepsy, meaning that they have not been focal that become generalized, but they are generalized from the onset. So those who have generalized epilepsy from the beginning, they're not a candidate for epilepsy surgery, as we talked. Someone who has a progressive neurological disorder as an underlying cause of the seizure. For example, one of them can be in the setting of dementia, for example, of Alzheimer's disease, for example. Alzheimer's disease is a progressive neurological disease. It will continue to worsen over years. And if someone has seizures as a result of the Alzheimer's disease, which is not uncommon, so that would not be a good surgery candidate. As we always said, this is a two-way highway, so it's communication, understanding of the process, cooperation with the process, because it's a long, fairly process for workup for the epilepsy surgery and eventually making determination or decisions. So someone who is not have the capability of comprehend fully the process or cooperate with the process or the procedure would not be a good candidate. Or if some individual may not have that, but they have guardians or healthcare proxies that makes decisions for them. The same, if the healthcare proxy or guardian did not fully capable of comprehending the procedure, probably it would not be the time to proceed before those communications are completed. And then there are certain relative contraindications for epilepsy surgery. So they're not absolute. In certain circumstances, we still consider them, but they are generally considered not a good situation to proceed with epilepsy surgery. And one of them, if you remember from the previous slide, we said psychiatric diagnosis. Most of them are not an issue with proceeding with epilepsy surgery, but there are conditions that someone may have a psychiatric illness that cannot be managed in a non-psychiatry ward. So that should be taken into account. And probably at that point of time, they may not be a good surgical candidate, but if things change, that psychiatric illness become under better control, that can be managed, like with routine medications without being admitted to a psychiatry ward, then that can't be considered again. And then if someone has severe intellectual disability, in those cases, also, the outcome of surgery is usually not very good because the underlying issue of the epilepsy that is associated with that intellectual also disability, lots of times results in kind of a poor outcome of the surgery, because this process most of the time is affecting the whole brain. So it's not just one single focus. So usually the outcome is not very good and usually not good surgical candidates. And then the other is that if high functioning parts of the cortex, what does that mean? What is high functioning parts of the cortex? So there are parts of the brain that in medical terms are considered high functioning, meaning that parts of the brain that handle the memory, for example, or parts of the brain that handle the language when we talk or when we understand others talk to us. So those areas, if the seizure focus in those areas, resecting them is obviously not a good idea. But there are lots of parts of the brain that their function can be compensated by other parts of the brain, and removing them doesn't cause much of an issue. So high functioning parts of the cortex, in medical terms, it's called eloquent cortex. If it's involved in that seizure focus, so that would not be a good surgical candidate. So in the few minutes that is left, I just want to mention again who would be, in terms of being a good surgical candidate. It also depends on the location of the focus of the seizure. So this is a cartoon of the brain. As a refresher, and lots of you probably familiar with this, there are parts of the brain are divided into lobes. So this is front part of the brain, this is back of part of the brain, and so hopefully you can see my mouse. So the frontal part of the brain is called frontal lobe. Parietal lobe is where more kind of the motor movements of the body is controlled in this area. Temporal lobe is the area that is usually kind of behind the ears, roughly. That's temporal lobe. Occipital lobe is the back of the brain, and that's where the vision is handled. So depending on the location, the long-term outcome of surgery can be different. But if I want to just make it kind of summarize that, is that the temporal lobe epilepsy usually has the best outcome. So about 50 to 80% of patients can achieve seizure freedom after surgery. But there are certain, again, pre-surgical factors associated with higher rate of seizure freedom. If for example, someone's seizure is not as frequent as someone that has more than 20 seizures per month. In other words, if someone's seizure frequency is less than 20 per month, there's a more likelihood to have a better outcome and become seizure-free. Or if someone has no history of generalized tonic-clonic seizures or grand mal, that sometimes it's known as, they may have a better outcome. And someone who has an abnormal MRI, again, so we have something in the MRI that we can focus on that is suspected to be the source of the seizure, those are usually better outcomes. So these are some, again, medical workups that determine, again, who might benefit more from surgery or be a better candidate for surgery than another. On the other hand, frontal lobe seizures have a bit less favorable outcomes. So about 50% of patients undergoing frontal lobe seizure surgery become seizure-free. There are factors, again, similar to temporal lobe that are associated with higher rate of seizure freedom. One is underlying cause, for example, if there is a tumor there, or if there is a part of the cortex that is called cortical dysplasia that is present there, or if someone had, trauma to the head, which is, frontal part of the head is very one of the most common areas of the brain that gets affected during the trauma to the head. So these are factors that can lead to or be predictive a bit of a better surgery outcome. The occipital lobe and parietal lobe, both of these areas, has the least favorable outcome of the surgery, so less than 50% of seizure freedom. And again, there are certain factors that can predict that. Is shorter duration. The shorter duration of the epilepsy has been, the better the outcome is. Usually children do better with the occipital and parietal lobes compared to adults in terms of outcome of the surgery. All right, I think that's all I have had for you today for the slides. And thank you for your attention, and we will go to taking questions. Thank you.